I'm talking mainly about antithrombotic drugs in the sake of time, but we will hear about other drugs in the acute phase during this session. Now here are my disclosures, and I would like to start with a first slide. And this is just an example how a patient with a STEMI or eventually with a very high risk non-STEMI should be treated in a hospital. And just show this because time is extremely important, and most of our patients should go for primary PCI if they have a STEMI, and also if they have a high risk and STEMI, they should be treated very early, if possible within 2 hours of the diagnosis. So what can we do with our patients? And you will see on the next slide that antithrombotic treatment is extremely important in our patients. We have, however, to evaluate the ischemic risk and the bleeding risk in our patients. Especially the bleeding risk is very important. And this and all these factors depend on patient characteristics like age, sex, race, and the history of ischemic or bleeding risk. The clinical presentation, and we are talking now about ACS, non-ST elevation, ACS or ST elevation MI. Comorbidities are important. They drive the outcome of our patients, a chronic kidney disease, diabetes, peripheral artery disease, or existing heart failure. And we need to know about the co-medication. For example, a patient already is on oral anticoagulants due to other reasons. And finally, also the procedural aspects. And we are now mainly talking about primary PCI, acute PCI in our patients. We need to think about femoral versus radial access, radial much better and much better also developed now, especially in patients with high bleeding risk. It should be used, but I think most of interventional cardiologists now use this radial access. And finally, also invasive versus a conservative management, which in some patients seems important. Now, which kind of antithrombotic therapy is available? And this is not only for non-ST elevation ACS, this also accounts for STEMI. And I just shortly want to go through the anticoagulant drugs that we might use. And with respect to an acute ACS situation where a patient goes to the cath lab, so it's usually unfractionated heparin or also the low molecular heparin, enoxaparin. Fondaparinux, not so much for the intervention itself, but in the preparation for the intervention. Then we have also bivalirudin tested in the past years. It's more expensive than unfractionated heparin or low molecular heparin, but has still its value in certain patients. For example, if they have a heparin-induced problem, or in patients with a high bleeding risk, it sometimes seems to be better. On the other hand, we have the antiplatelet agents. And here mainly we have aspirin, and usually it's combined with the so-called P2Y12 inhibitor. In the acute phase, this should be prasugrel or ticagrelor. If these two drugs are not available or there are contraindications, clopidogrel also can be used. And also cangrelor may have some role in this situation, especially if patients are not pre-treated with the oral P2Y12 inhibitors. I don't want to go too much into detail now with other drugs that have lost their importance in the majority of patients during the past years. Now, what about antithrombotic therapy in STEMI? We have a 1A recommendation for a potent P2Y12 inhibitor, prasugrel or ticagrelor. Here we can use clopidogrel, as I told you, if the two drugs are not available or there's some contraindication. We have a clear indication also for aspirin that should be given in these patients. And here you can see that a glycoprotein inhibitor only should be used in a bailout situation. And also for cangrelor, we have only a very moderate recommendation in specific situations. Now, what about the antithrombotic therapy with respect to the anticoagulants? And here it's clear we have clear recommendations. This is all expert related, as there are no comparable good data compared to the antiplatelet drugs. But here first we have to use antiplatelet therapy, and usually it's unfractionated heparin or a low molecular heparin. And here mainly enoxaparin, especially in France, and also bivalirudin can be used in certain situations. The routine use of enoxaparin and piperacillin is not recommended for the majority of our patients, but are still used in certain countries and regions. And fondaparinux is not a drug for the intervention itself. Now let's come to the anti-robotic therapy in non-ST elevation ACS, and here the antiplatelets treatment, a clear recommendation 1A for aspirin, a clear recommendation for P2Y12 receptor inhibitor in addition to aspirin. And here you can also see that this usually should be given for up to 12 months. And then you can see that prasugrel now seems to have a better recommendation than ticagrelor. I come to this in a minute. And on the next slide, you can see also ticagrelor can be used irrespective of the planned treatment strategy, while prasugrel should only be used in the cath lab. So it should not be given as a pre-treatment based on the data of clinical trials. And finally, also clopidogrel can be given, especially if the other two drugs are not available. And here you see a 2AB recommendation now that prasugrel eventually should be considered in preference to ticagrelor for these non-STEMI patients who proceed to PCI. Now, on my next slide, you see now the anti-robotic therapy non-STEMI, and you can clearly see, and this is relatively new in the new guidelines, that we now define 3 groups of patients. One, patients with a very high risk. These patients usually are brought to a PCI center, and they usually in this very high risk should have an immediate invasive diagnosis and treatment within 2 hours, so very similar to STEMI patients. So what drives the very high risk? This is given here in this slide: the hemodynamic instability, patients in shock, recurrent refractory chest pain despite treatment, life-threatening arrhythmias, and so on. Now then you have patients who have a high risk, and such patients either can be transferred directly to a cath lab, or they may come from another hospital with a so-called non-PCI center. In this case, they have been transferred the same day, and usually these patients should be treated within 24 hours, so early invasive. And you can see here again how a high risk is determined. And there are other patients, so we have no moderate or in-between group as we had in the former guidelines. So all the other patients seem to have a lower risk. They can be treated selectively invasive, which usually occurs within 48 to 72 hours. And in a patient with a very low risk, you can also do some other investigations before you go for invasive treatment. And for sure, in all of these high risk or very high risk and low risk situations, there may be certain patients who are very old, have comorbidities where you in certain situations, maybe not in the very high risk situation, but in this patient where you think about a conservative treatment, but this should be the exception and depends on the individual situation of the patient. Now, with respect to the antithrombotic therapy in patients who undergo PCI, I would like to show you that cangrelor may be considered in P2Y12 inhibitor naive patients with a 2BA recommendation. So this is not very frequently given. It depends again on the centers that use this drug. We use it eventually in about 5 to 10% of our patients coming in without a pre-treatment, but it's relatively rare. And what I would like to show you and also the pre-treatment with a P2Y12 inhibitor may be considered in patients who are not planned to undergo an early invasive strategy and do not have a high bleeding risk. So this is for patients who are not treated within 24 hours. So due to organizational problems, some of these so-called high-risk patients are not treated very early. And now the question is, should we use a P2Y12 inhibitor in front of the PCI? This is usually no more recommended if you are quick with your patient, but if you are not, so this is still a situation which is done in many centers and also recommended with a relatively low recommendation by the recent guidelines. With respect, I have here another situation I would like to show you. So this is patients who come into the hospital, N-STEMI patients, and here this is patients who where Fondaparinux could be a good idea, if, for example, in the way to the hospital or in the emergency room. This can be a drug that helps to bridge the situation until a PCI, but as soon as you go for intervention, you need to switch to unfractionated heparin or low molecular heparin, whatever you're usually using. And here is my last slide, and I just would like to focus again on the upper part of the slide. Here we have a patient with a non-STEMI, and we heard about the anticoagulation, could be unfractionated heparin or enoxaparin, or in certain situations the bilirudin. So this is given to most of our patients. All these patients will usually receive aspirin, on the way to the cath lab. But then we really have to look at the bleeding risk, and bleeding risk is much more important in the secondary prevention of these patients, so in the treatment up to 12 months or even longer. But this is a topic that will be presented by our next speaker, Janine Ruthers von Lennep. Thank you very much for your attention.